안녕하십니까? 오늘 이 자리에서 여러분에게 프레젠테이션을 하게 되어 정말 영광입니다. Thank you so much. It's wonderful to be presenting virtually, although I wish I was in Korea. It's also an honor to follow such notable rhinologists who are talking about the global impact of chronic sinus disease and its endotypes. Today, I'd like to talk about current and future changes to rhinology education. One common theme that brings us together internationally is the need to train the next generation of ENT surgeons efficiently and optimally. Traditionally, our education has been step-based. For example, medical students may learn about anatomy and physiology from textbooks, but it doesn't really stick without the clinical relevance to disease. Many residents are expected to learn how to hold and manage endoscopes in surgery without sufficient exposure to cadaveric dissections or in-person teaching. So the challenge in step-based learning is that once you're promoted, you're frequently not prepared for the next step. In this next generation of education, I advocate that we need to transition to slope-based learning. In slope-based learning, our goal is to provide fluid training that can incorporate tasks of multiple levels and better prepare trainees for the next step. Today, I'd like to talk about two of our projects, including self-directed education, as well as simulation, that leverage advances in technology to improve rhinology education and training. Our first project was designed for medical students and junior residents. How many of us remember the utter confusion that we had when we were watching our first sinus surgery? I may be dating myself, but the first time that I was able to look through an endoscope was actually through an eyepiece. When my attendant came over and let me take a look and said, "Here, look, here's a middle turbinate. Can you understand the anatomy?" When I did take a look at through the eyepiece, all I saw was a field of red. He looked at me with eager anticipation. I said, "Yeah, of course, I can see the middle turbinate. That is so cool." But in reality, it really didn't learn anything. Obviously, with modern endoscopic cameras, teaching is so much easier. But for students, sinonasal anatomy can still be very difficult to understand, in part because this area is so challenging to teach in gross anatomy. I know that in my first year cadaveric course, we were not really able to access a sinus anatomy. And even still, it's really hard to get cadaveric courses for many of our residents who are engaged in sinonasal surgery. We have learned that self-directed learning, where students could access videos on their phones with a total length of less than 10 minutes, was critical to capture their attention. These videos introduce not only the what, but the why, and that's really important. For example, we not only identify the lamina in these videos, but we also explain why injury to these structures could result in vision loss. We are currently testing the efficacy of this video through a multi-center randomized trial. Students are given a pre-test and a post-test to determine if we can improve sinonasal anatomy awareness as well as relevance to clinical conditions. My overall goal is that if I can prevent one unnecessary consult of a nasal polyp, which actually ends up being an inferior turbinate, I count that as a success. Our second project is our mixed reality simulator, designed to increase exposure for residents in a safe and repeatable environment. Residents can segment critical structures from patient CT scans, and then they can build 3D models in which they can navigate, so they really understand the spatial 3D anatomy that's so important for surgery and is so hard to teach through a two-dimensional format like radiological films or textbook figures. We now have high-resolution 3D printers that can create physical models of a patient's anatomy prior to surgery down to the millimeter level. This skull can then be tracked and manipulated in real time using technology identical to that we use every day in navigation-based endoscopic sinus surgery. So how do we bring this all together? Well, we can create an immersive virtual reality environment in which we can not only simulate surgery, but coach trainees through the process. Here's our first version of our simulator tutorial, in which residents are guided through the steps of endoscopic surgery while using VR goggles.
Welcome to the first VR neurorhinology simulator. In this interactive teaching module, you will learn the basics of nasal endoscopy. This includes how to hold and operate an endoscope with different angle views. By practicing with a virtual endoscope, you will learn what critical structures are involved in a basic VES case. Lastly, using the virtual instruments, you will practice the steps involved in a maxillary antrostomy. Start by lateralizing the inferior turbinate. Next, medialize the middle turbinate. Okay, you'll want to switch to a 30-degree scope now. Hit the button on your endoscope controller. Now, place your suction at the maxillary os. You should now see where there's been a maxillary antrostomy. Finish it by taking down the uncinate process to your 0-degree scope. Define the medial orbit by dissecting the ethmoid bulla. Note that the sphenoid os is identified by a yellow sphere. Use your suction tip.
So what I'd like to highlight here is that not only is this an immersive process where it replicates what surgery really feels like, but it's also educational with the addition of our virtual coach in which highlighted structures are addressed. There are guides throughout the surgical process, and we can also adapt this to different levels of difficulty based on trainees' needs. Although immersion and realism are important in simulation, the ultimate goal is to develop a program that can provide direct and unbiased feedback on trainee performance. Our first step is to break down each surgical procedure into surgemes or tasks, and then provide criteria for success. Most of the surgical simulators available today collect static data collection, such as time taken to perform a procedure. Our simulator is unique in that it collects dynamic data, including measurement of tools and endoscopes in 3 dimensions within the sinonasal space. How many of us have seen true masters of surgery perform and operate so easily? These dynamic measures will allow us to test and train for surgical fluidity as well as efficiency. We're also able to identify how many times trainees might hit critical structures, such as the lamina or the skull base, or how many times their tooltips might hit. Using these methods, we ran 48 subjects through our simulator, 24 novices and 24 experts. What we found was really interesting. We used an artificial intelligence or AI module to see if we could predict, based on this data set with a relatively small number of samples, who was a novice versus who was an expert. And what we found was that based on these 3-dimensional movements, we were able to predict the classification in greater than 80% of cases. As you can imagine, as this data set continues to increase and more people continue to use a simulator, this increased accuracy will also go up as well. Simulation is also best used to replicate high stress and high risk, but very rare complications. In sinus surgery, for example, one of our rare but high stress complications is an anterior ethmoid bleed that retracts into the orbit, resulting in an orbital hematoma. In this situation, the correct management of this complication can define if the patient wakes up and is able to see or if they're blind. I participate in a workshop sponsored by the AAO, and we review these algorithms for these situations. However, imagine not only reading about them, but being able to simulate them in real life. In our version 2.0 of our simulator, we've now incorporated bleeding, we've incorporated tissue movement, swelling, and edema, as well as implemented these complication scenarios to see how our trainees react and also educate them on what to do when these complications occur so that they become second nature. I wanted to thank the International Committee for inviting me here to speak today. Thank you so much. I was so excited to present at this meeting. I hope that someday soon we'll be able to see each other in person. I also wanted to thank all of the people and institutions involved in this project. Dr. Bailey, our rhinology fellow, was a driving force behind our curriculum videos. Dr. Lay is my partner who helped to validate these videos. And Jordan Grauer is our medical student who helped to implement the illustrations for guidance in our surgical endoscopic videos. We also have developed a multi-center collaboration in order to test the efficacy of these videos. And if you're of any interest of participating with us, we'd love for you to join. Doctors Barber, Jane, and San were very helpful and instrumental in creating this mixed reality NRS simulator. And of course, this work could not have been completed without our funding sources. Thank you very much, and I'm happy to take any questions.